Good afternoon, everyone, and thank you for joining us on this February, cloudy kind of February afternoon. Happy Valentine's Day to all of you. I hope you all are wearing your red in honor of heart health and Valentine's Day. And what an appropriate day for us to have our presentation on heart health. For those of you that I have not had the pleasure of meeting, my name is Sandy Haas. I am Executive Director of the Retirement Association and will be serving as your host this afternoon. In addition to our distinguished speaker with me today, are our program coordinators, Wendy Way and Susan Fisher. It is my pleasure to introduce a member of our Retirement Opportunities Committee, who is serving as today's lead program coordinator. Please join me in welcoming Wendy Way for the purpose of an introduction of our distinguished speaker. Okay, Wendy, it's all yours.
Okay, thank you so much, Sandy. Good afternoon and happy Valentine's Day, everyone. February is not only the month when we celebrate Valentine's Day. Since 1964, February has been designated by the federal government as American Heart Month. Since first declared by President Lyndon Johnson, it's been envisioned as a time when all people could focus on not just on Valentine's cards and heart-shaped candies, but on their cardiovascular health. And so today I'm really pleased to be able to introduce an expert who can help us do just that. It's Dr. Adam Gepner. He's going to talk with us about how to really love your heart by sharing advances in and strategies for caring for heart health. Dr. Gepner is a faculty member in the UW-Madison Division of Cardiovascular Medicine with his primary practice at the William S. Middleton Veterans Hospital here in Madison. He's the director of the Madison GeroFit program, which is an exercise program designed to promote health and wellness for older veterans. Dr. Gepner's research focuses on improving blood pressure control and better defining blood pressure goals in older patients with and without cardiovascular disease. He also studies the epidemiology behind blood vessel stiffness and how it's impacted by aging and cardiovascular disease risk factors. Dr. Gepner has won many awards for outstanding research and teaching, including an American Association of Medical Colleges Young Investigator Award and the Cardiovascular Fellowship Outstanding Educator Award. Dr. Gepner, thank you so much for being with us today. I think we're ready, if you're ready to share your video, and I'll turn things over to you.
Wonderful. Well, I hope that all of you are ready to learn a lot about heart health and what it means to stay healthy. This is an incredibly great opportunity, and I'm so happy to be able to share on this special day of all days. So let's get started. But if you want to take down my contact information or follow me on Twitter, you can definitely get some content there as well after the program. All right, can everybody see my slides? Wendy, can you confirm?
Yes.
Okay.
Yes.
I do have one disclosure. I am the owner and president of Beam Healthcare, which is a telehealth company that's nationally known. But that won't be a big part of the talk today. We'll talk very minorly about some health technology that has nothing to do with my company. And this presentation is interactive. This is a chance for all of us to really come together and find out what others are thinking. And this really helps me tailor the presentation to the types of people who are participating. So if you have a smartphone, grab your smartphone and pull up your text messaging if you have text messaging capabilities. I'm going to do it with you. So pull up a text message, a blank text message like this, and type in this number. You're going to be sending a text message to this number, 37607. And the message that you're going to send is my name, Adam Gepner, 385. And that will link you to our poll. So I made Wendy and Sandy try this earlier to make sure that it was working. And so hopefully it'll work for everybody here too. So again, if you don't have a smartphone and want to follow along on your computer, you can go to this URL, which is pollev.com/Adam Gepner 385, or you can send the text message. Both will take you to the same poll. All right, so with that, I will switch over to our first question. And so the first question is, do you love your heart? And I gotta get back to my share to share my other screen. Okay, so you should be able to see this question. Wendy, can you confirm that you can see the question now? Do you love your heart? And if you want to respond, A, B, C, or D. So if you love your heart, this is again just to kind of see if everybody can get there. And looks like we've got 5 total results now, 6. Great, looks like some people are getting the hang of it. Wonderful, we'll wait a little longer to see if other people can get logged in. And remember, the information is right up here. So you can either text Adam Gepner 385 to this number, or you can go to Poll Everywhere. Or if you're not feeling tech savvy today, you can just play along in your mind. All right, we will see what the responses are. All right, looks like a few people want cupcakes, but most of us are ready to roll. All right, and again, just a little bit more information about you guys. I'm interested in finding out your ages, again, because a lot of the content is specific for people who are older. An idea of what type of audience members we have will really help me. I'll play along too. Wonderful. That didn't work. All right, getting back to our screen share here. Okay. All right. So we know that people are a pretty wide spread of ages. So thanks for sharing. That helps me figure out what type of people are listening in. So the next question, I want you to think about is how you would rate your overall health. And again, this is important because I'm interested in knowing if people joining this call are on the healthier side, or if you have things that you can improve upon. And we will jump back to our poll question slide. Okay. So if you would rate your overall heart health as excellent, hit A and send that. Very good. B, good. C, fair. D, and poor. E, and if you have no idea, go ahead and hit F. And great, it looks like everyone's getting the hang of it, which is the whole point of having a bunch of questions at the beginning. Oh, we got some excellence out there. That's fantastic. Wonderful, a few more coming in. Great, well, thanks again for answering those questions. We'll switch back to the presentation, and thanks again for bearing with me as we go back and forth. Again, I think it's more fun when it's interactive. All right. All right, so you should be able to see my slides. So aging really does matter, especially when we're talking about cardiovascular disease. And this is because on a whole, we're living much longer. But as a provider and a cardiologist, that means my patients have more comorbidities or medical problems. It means that people are on a lot more medications, and sometimes new medications that are coming out rapidly. There's some conceptions out there that are more societal, like, are people too old for invasive procedures? And should people who are older have very aggressive care or not? And all of these are questions that have come up in my practice on multiple times. And I'm sure as patients, they probably have come up for you too. But everybody is aging. And one of my main missions is to try and help people age in a healthy way and age functionally. And you can see by the blue line, over the past 20 years, we are showing exponential growth in the number of people who are over 65 and the number of people who are over 85. So I think all of you can relate to this slide. I certainly can. And it's no surprise that as we get older, the risk of having something bad happen, and in this case, this is a graph showing different age brackets and the number of hospitalizations for cardiovascular disease per 100,000 people. And you can see once you get into the 60s, 70s, and 80s, the number of people who are being hospitalized, both men and women, exponentially increases. This is one of the founding fathers of cardiology. This is Eugene Brunwald, and he just wrote an editorial about how to live to 100 before developing coronary artery disease. Well, I hate to say it, but Eugene Brunwald's only a spry 92 years old. But a lot of the things that he talks about are really important, and some of them I'm hoping to touch on today. Okay, so what are you doing now to stay healthy? And I'm going to switch to the poll. Thanks again for bearing with me. And I will share my other screen. Okay. So you can actually free text in what you are doing, and this could be anything. So I'm going to just test it out here. Oh, and I think this one, it might not be working because I got a response back. So this will just be more of a thought question. And again, thanks for bearing with us with our tech. But think about what you're currently doing to stay healthy. Are you eating right? Are you exercising and staying active? Are you thinking about things that are bring you joy and keep you happy? Oh, somebody was able to text in, so I'm not sure why I wasn't, but I think a lot of us are doing a lot to stay healthy as we get older, and that's really important. We'll switch. Oh, yeah, thanks. Yeah, exercise, monitoring blood pressure. Great. Tai Chi, Pilates, watching weight. Wonderful. That's great. These are all great things that you can be doing. And I think that's one of the key points that I'd like to make is that there's a lot of things that we can be doing to stay healthy. And I think one of the first things we need to do is really just take stock of what we're already doing. Because what I know from taking care of a lot of people who have heart disease and who want to prevent heart disease as they get older is that small changes really make a big difference. Oh yes, love the low salt diet. And we are going to touch on all of these. And I'm really excited to share more. So let's get back to the presentation and we will share. Yes, lots of stuff still coming in. Growing your own vegetables. I love it. So I'm glad you guys are doing a lot of things to stay healthy. So we're going to talk about aging in general. And then we're going to switch gears and talk a little bit about frailty. And frailty is an up and coming marker of lots of different risks in terms of getting older. And cardiovascular risk is no different. We'll also talk about two of the most common cardiovascular disease risk factors, hypertension and dyslipidemia. Or you probably know them as high blood pressure and high cholesterol. And we're also going to talk about how to have a conversation with your medical provider. Because age is really not just a number. I think we can all relate to the fact that you might look at somebody and say, wow, that person looks very old, only to find out they're in their late 50s or early 60s. On the other hand, maybe you look in the mirror and you see a 60-year-old person, but really your chronological age is in your 80s or 90s. And that's something that I think is really important to remember is age is not just a number. And we can't treat people for cardiovascular disease based on a number. We have to meet people where they are. I'm going to meet you where you are and treat you as a person and not just as a number. And that has big implications because we know that while age has a lot to do with outcomes in terms of cardiovascular disease events like heart attacks, strokes, and dying, we also know that older individuals who are at the highest risk also benefit most from our treatments. And we'll talk a little bit more about that. The most important thing that I can do as a provider is have a systematic approach to treating people that really takes into account the entire person and not just their age. Cardiology is a rapidly evolving field, and I'm so happy to share with you that we have had a huge surge in the amount of literature and research that's being done on older individuals. And this is going back to the mid 90s, and you can see the number of US adults is going up, and the number of landmark cardiology trials incorporating older individuals has also gone up. And by 2020, which was just a few years ago, this article came out in 2018. You can see that we're still making progress, and I would say more than ever. When I look for data on older individuals, you can see that since the year 2000, there's just been an explosion in the number of peer-reviewed medical journals that have that come up under the search geriatric cardiology. And this is great because historically, a lot of data in cardiovascular disease risk has really excluded people above 70, 80, and 90. So I hope to share with you today some of the information that's specific to this demographic, and I know that that's going to be relevant to you. And here's just the number of publications that we've seen. And in 2021, we are well over 1,200, and I have no doubt that this will continue to rise in 2022. And again, the big things that I want you to remember is heart attacks happen, and they happen more when people get older. And this isn't meant to scare you, but this is meant to be a reminder, because everything that we're doing today impacts what happens tomorrow. And if we want to live to 100, like Eugene Brunwald, without cardiovascular disease, we really have to think about these things every day. And I think this is just another slide that illustrates that in a slightly different way. And again, you can see that people who are over 70 and have the highest risk, with the people over 75 being at greatest risk for heart attacks, strokes, and even death. So this gets into our next topic, which is frailty. So our next poll question is, what is frailty? And this is a hard question that even medical providers struggle with. And I am going to pull up the poll questions. Yeah, great job on that last one. And I am going to share the first screen. Okay. And we are going to go to our next question, which is, am I frail? And this is designed to help us determine if people are frail in the audience. So the first question I want you to ask is, are you fatigued or tired? And keep track over the next several questions of your total score. So I'm going to play along as well. Oh, I have to activate this poll. There we go. Now it should work. So again, take some time, think about this. Are you tired? Are you fatigued? And this doesn't mean like I didn't get enough sleep last night. It's like, are you kind of dragging as the day goes on, not able to do the things that you want to do because you're too tired? Great. So keep track of that. The next question is, can you walk up one flight of stairs without stopping to rest? And if the answer is yes, you can, you do not get a point. If the answer is no, you can't, then you do get a point. So again, we'll see. Oh, I have to activate this one too. Sorry about that. Now it should work if you were trying before. So again, keep track of that. See if some other responses come in. The next question is, can you walk? Oh, that's incorrect. The next question is, do you have more than 5 illnesses or medical conditions? And if the answer is yes, you get a point. And if the answer is no, you don't. And again, this should be active. So I'm going to try and respond. Some of these multi-question polls might be a little glitchy in the chat, it looks like. Yeah, so I'm not getting a good response there either. So we will go back to our slideshow.
As if they're having problems.
All right.
Adam,
Yeah.
Susan here. Say, I'm getting a message from the polls saying your presenter has not opened the poll yet, and it was working fine, and now it's not.
Yeah.
So
Okay.
for some reason, it's shut.
Yeah, I think that it should work now. I think I needed it to be active, but that's okay. We will swerve. Thank you so much for letting me know that.
You bet.
And we will get back to the presentation. Right. Maybe we will get back to the presentation if I can find it. Usually I embed these in the talk, but today was not a good day for that. And then actually we'll do, since we'll try this one more time because I think now that I activated it, it should work. So the next question after 5 medical illnesses is, have you lost greater than 5% of your body weight in the past 6 months? So if you're losing weight, this would be unintentional weight loss. So if you're trying to lose weight and you're making progress through diet and exercise, that would not count. Great, looks like it's working again. I apologize for that. Wonderful. Okay, so once you have answered those questions, the next question is to add up all your points for those 5. And if you have 0 points, meaning then you would put A, and if you had 1 to 2, B, and 3 to 4, you would have, oops, that doesn't look right either. So great, it looks like a lot of people were able to share their answer, and now we will bounce back to our presentation. Okay. So what is frailty? The problem with frailty in the medical literature is there's really no gold standard definition. There's lots of tools to assess frailty, but there's none that have come out as this is the end all be all of how we define it. But we all know that frailty is increased vulnerability to different stressors. And that could be physical stressors or mental and emotional stressors. So if you think about it from a visual standpoint, if functional status, meaning these are the people up here who are the most functional, and age is on the x-axis down here. Most people, as they get older, are very functional, able to do all of the things they want to do. But as they develop medical conditions and illnesses, or maybe have an injury or a fall, we oftentimes will have these dips in our functional status. Now, sometimes we can recover from those and heal, and we might never detect that that person was frail. But over time, as we keep having events, frailty becomes more and more detectable over time. Another way to think about this is thinking about it in terms of being pre-frail and developing where you have a response to the stressor that is clinically silent. In other words, you wouldn't have any problems passing the test that we just gave you. But if you're already frail and you have a stressor, you may not come back to where you were. You may have more clinical deterioration over time. So I like to really talk to my patients, and I want to talk to you about the opposite of frailty. And really what this means is being a robust older adult. And I'm not, in the interest of time, I'm not going to go back to the poll, but think about the type of words that come to mind when you think about a robust older adult? Or maybe it's a person that comes to mind. You have an image of somebody or a family member who you really think, wow, that person is a very robust older adult. They're not frail at all. And I have a lot of patients who come to mind. But the most important thing to remember is if you are frail, that means that you are at increased risk. So this is the frail instrument. This is what we just went through in the poll. So these 5 questions: are you fatigued? Can you walk up a flight of stairs? Can you walk 1 block? Do you have more than 5 medical illnesses? And have you lost greater than 5% of your weight in the past 6 months unintentionally? This is a well-validated instrument, but remember, this is just one instrument. So if you answered these questions and you had a score of greater than or equal to 3, that indicates that you do have frailty. If you were 1 or 2, that means that you were in the pre-frail category. If you had 0 of these, then you are truly the epitome of a robust older adult, and I commend you. The good news is frailty matters, and we can improve it. So this is a study that was done. It's called the Cardiovascular Health Study, and it was an observational study of 2 cohorts that were followed for 7 years that included over 5,000 US men and women who were over 65. And what they found was that people who were frail after 3 and 7 years had a significantly increased risk of death, hospitalization, falls, and decreased mobility. So this is a big deal. Now, it should be pointed out that even the group that was not frail still had some of these events, but at a much lower rate than the pre-frail and the frail group. When we look at the percent of enrollments who were alive after 96 months, you can see if you were in this frail group, if you had greater than or equal to 3 of those measures, the risk of you dying was significantly higher versus the people who were robust. Really very few deaths occurred in that group comparatively. But there are problems with frailty markers. Like I said, there's 40 operational definitions. Actually, there's more than that in the literature, and they're all slightly different. Some focus on historical data, some incorporate laboratory data like blood tests, and others incorporate functional or objective data like some of the questions that we asked today. Gait speed, grip strength, and chair stands have all been studied with regards to frailty and also are associated with different metrics. But really, without a gold standard, we are in the dark a bit. And so this is one of the big things that I hope to impart to you, is that this is an area that needs continued study, but we do have a lot of information about how this can be used to help. And this is just to illustrate that depending on which type of test you use, each one of these is a different frailty test. Using the same people, you can see how different the frail and unfrail individuals are. So that the prevalence can change from 4 to 60% depending on the instrument that you use. And pre-frailty can change as well, from just under 20% to over 50%. So the instrument does matter. And I think this really speaks to how complex the frailty syndrome is and how it impacts your cardiovascular disease risk factors and your cardiovascular health, because there's a lot of physiological drivers of frailty, and there are things that we can do to prevent that. So there's environment and there's genetics, and these are all intertwined. This is complex, but I hope to give you some pearls about what you can do to make sure that, one, you're preventing yourself from becoming more frail or even building up robustness. So the answer to that question is yes, as you imagined. And there's lots of different interventions that are aimed at preventing or reversing frailty. And we think of this as primary prevention, where you're already robust. How do we keep you in that robust category? And if you are pre-frail, how do we keep you from going to frail? And if you are already frail, how do we improve your quality of life or prevent you from having problems because of frailty? And this combines a lot of different things. It combines your physical fitness, thinking about what medications you're on, thinking about mental health, nutritional health, and cognitive health. So we can make, as clinicians, a comprehensive geriatric assessment of our older patients. And this allows us to think about you as a person and personalize a care plan to prevent you from becoming more frail. But that is really important to ensure that you're giving your provider good information about what's important to you, because what's important to you might not be important to someone else or to the person sitting next to you. So goals of care matter. And unless you have a discussion with your provider about goals of care, it's really hard for your provider to know what's best for you and what's right for you. What's the problem with that? As providers on a whole, we're really bad at talking about goals of care, because sometimes that means talking about things that are hard to discuss, like what would happen if you had a heart attack? What would happen if you got sicker, or if the disease state that you had got worse? What would you want your life to look like? So those are some very personal and difficult conversations to have. And I think for me personally and my patients, the more that we have those conversations, the more beneficial that they can be and the less difficult they become. Because I think the first thing is just thinking about it. And I'll give you some tips on how do you talk to your provider about your goals of care as we go through the talk. And the last one is a question mark. And this comes up a lot because there's a lot of technology out there that we can use to improve physical, mental, cognitive health. And how can we harness that technology to improve frailty? So back to the poll question, and we'll just flip back here if we can. Have you had a goals of care discussion with your provider? And I'm going to get back to our poll, and we are gotta get into okay, present. Okay, have you had a goals of care discussion with your medical provider? So if you have, go ahead and hit yes, and if you haven't, hit no. Oh, it's great to see that a lot of people have, but I'm definitely seeing more who don't, and some people who don't have a provider, which is also a problem. And remember, this doesn't necessarily need to be a cardiologist. This could be your primary care provider or a provider or specialist that you see regularly. And these results are not surprising, because I would say in my experience talking to people, probably about 2/3 have never even thought to have this type of discussion with their provider, and provider hasn't brought it up. And a lot of times this is because there's so much to do in a visit. There's lots to talk about. And again, this takes up one of our most valuable commodities and one of your most valuable commodities, which is time. But I think, again, in order to have the best possible care, knowing what your goals are is incredibly important. And we'll share the slideshow again. So thanks again for answering. Okay, so on to harnessing technology to help with improve cardiovascular disease outcomes. And I was lucky enough to be the vice chair of a committee a few years ago that really focused on how we can harness mobile health technology to improve cardiovascular disease prevention. And there's a lot of great information out there. And I think you all, with your tech savvy skills getting in the poll everywhere, have really shown that 80% of adults over 65 own and use a cell phone. 67% of adults over 65 use the internet. And now Americans over 60 are spending more and more time in front of screens. And if you're over 60, the average is 4 hours and 16 minutes per day on tech devices. So contrary to popular belief that older individuals are not tech savvy, the data just does not support that. Also, 2 to 7% of adults over 65 are using fitness trackers, and that is actually older data, and there is suggestion that that number continues to rise as you'd expect. So in terms of harnessing technology, there's a lot of different technology out there. There's these devices that can help us track our fitness. They can help remind us to take medications. They can track if we're having heart rhythm problems. And all of that can be done fairly autonomously without much person involvement. And that data can be directly transferred via Bluetooth or Wi-Fi or cellular data to providers so that they can help you make real-time changes or reinforce the healthy behaviors that you're already doing and notify you if there are concerns. So this is something that is on the forefront, and that's going to be more and more common as technology continues to improve. So look for this as the years go by, and most of you are probably already seeing this already. But regardless of how we're doing it, prevention of cardiovascular disease is the key. It's much harder to go back once you've developed cardiovascular disease and really get back to where you were, especially as we get older. So prevention is key. And robust older adults should be treated similar to younger adults. And again, that's because those individuals have the most room for benefit. And what we should be doing as providers is, if you come in to my clinic and you have symptoms or signs of cardiovascular disease, I'm going to screen you regardless of what your age is. Now, if you had a goals of care discussion with me and you said, you know what, I know that I have medical problems, I really want to avoid tests and treatment at all costs, that's great, because that's important information that then I would use to guide your specific treatment plan. But in general, for robust older adults, we should be screening. And there's also more and more data in older adults, particularly in the 65 to 75 year range and the 75 to 85 year range, that aggressive risk factor modification can really help improve cardiovascular disease outcomes. And what I mean by that is preventing heart attacks and death. And because we are in the older demographic, we really need to pay attention to the increased risk of adverse effects with medication. And that's different for everyone. And that means weighing the risks and benefits of specific treatments. If you're on a medicine that makes you feel terrible, but it improves your longevity, that's a risk benefit discussion that we need to have, because what's the point of living longer if you're feeling miserable? And that's where shared decision making comes in, and having discussions with your provider about how your treatments are impacting your life and how they're impacting the potential for future harm. So again, screening and preventative measures should align with your goals and preferences. Some of my patients have limited life expectancy, and we both know that, and we talk about it. And if that's the case, then sometimes we can get rid of medications that we know might help over 10 years. But if your life expectancy is only 1 or 2 years, then you're probably taking an extra pill that might have side effects for nothing. One of the things that we can all do to prevent cardiovascular disease is exercise. And I know from our discussion earlier, a lot of people are already doing exercise. The American Heart Association recommends moderate intensity exercise for at least 150 minutes per week. Moderate intensity means that you can still speak comfortably, but you're starting to feel a little out of breath. If you are just starting an exercise program and you have health issues, I definitely recommend talking to your provider about that. But in general, starting slow is the best way to go. And when I say start slow, I mean, I've had patients who've started with a walking program for just 1 minute a day, and then slowly building up to 2, then 3, then 4 minutes. Some people can't walk. Some people are in wheelchairs, and in which case there's other activities that you can do in a chair or without getting up that can really help improve fitness over time. But the key is starting slow and finding an activity that works for you. One program or a couple programs that I want to highlight are the Active Living Every Day, or ALED. And if you look up, because I know you're all tech savvy, if you look up ALED and active aging, you'll see a whole bunch of programs that are geared towards older individuals to help them stay active. And this is a lot of the things that you guys had mentioned in the chat, like Tai Chi or water aerobics or doing low impact fitness. Remember, it doesn't matter what the activity is, it matters most that you're staying active. Silver Sneakers is another program that I'm sure many of you have heard of, which again incorporates activity for older individuals, and you can find information online as well. And if there's any veterans in our office, I'm the director of the GeroFit program in Madison. It's a national program that's really just like these other two programs, geared towards improving strength, balance, flexibility, and cardiovascular fitness, but it's specifically geared towards veterans. And right now our program is all virtual, so people don't even have to leave their house. And all of these programs have good outcome data, but in GeroFit, this was published several years ago, but we looked at 70 veterans who were enrolled and compared them to people who dropped out of GeroFit in less than 6 months. And we found that there was a 25% lower 10-year mortality in the people who stuck with it. And again, this is GeroFit data, but we can extrapolate this to any exercise program. And we know that if you stick with it, even if you're doing just a little bit, that's going to be beneficial over time. So again, in summary, we need to have a comprehensive assessment of our older patients to help people improve their overall health. And that means taking good cardiovascular history, screening for frailty and falls, talking about the hard discussions, like what are your goals of care and your care preferences, and really thinking about who can help you, and particularly if you have problems or injuries or illness. So I'll pause there. And if there are any questions in the chat, we can talk about aging and frailty. Otherwise, we're going to move on and talk about those two very common and specific risk factors, starting with hypertension and then moving on to high cholesterol. So we'll give people a second, but I'm not seeing anything pop up unless, do you see a question in the chat?
No, I don't see any in the chat, but if people have them, they can certainly add them. But maybe you're going to address this, but one of the questions that I had as you were talking was, are the strategies for maintaining heart health that you've touched on, are they different for men and women, or are they different for people of different racial or ethnic backgrounds?
Great question.
Maybe you'll get to that, but
In general, we'll talk a little bit more about this. In general, men, women, people who are white, Black, Asian, Hispanic, all have the same basic core principles, which is prevention of cardiovascular disease is ideal. And we all do that the same way, through healthy diet and through active lifestyle. There are definitely some nuances as it relates to men and women's different risk factors, which we'll talk about. And race and ethnicity also has some nuances. But in general, those core principles, doesn't matter what color your skin or what your sex or gender, everybody ages at the same rate, and age is the biggest risk factor, which we can do nothing about. So, but that's a great question that we frequently get in clinic.
Let's see. Another question is, what tests constitute a cardiovascular disease screening?
I'm sorry, I missed that.
The question is, what tests constitute a cardiovascular disease screening?
Great question. So cardiovascular disease screening can mean a lot of different things, and it depends what symptoms you're presenting with. So the most common that we use in our clinic, or people who get referred to our clinic, would be an electrocardiogram, or ECG, which is an output of the electrical recordings of your heart that can tell you if you have heart rhythm problems, or a stress test. And there's lots of different types of stress tests. So if you're having chest pain or discomfort with activity, or shortness of breath that's more than you would expect with activity, that can be a sign of coronary artery disease, in which case we would screen with a stress test. But there's lots of different modalities of cardiovascular screening depending on what your symptoms are. Great question. Any others that popped up? Otherwise, hopefully I'll address more as we continue to talk about.
Adam, excuse me, there was one question, and it was, how does one join GeroFit?
If you are a veteran, just talk to your VA provider. And if you don't have a VA provider and you're a veteran, just email me and I'll help you. Great question. All right, we'll move on to hypertension, and if there's more questions, we can definitely get to more at the end. We'll have plenty of time. Okay, back to the poll. Do you have high blood pressure? And I'm going to switch to the other slide. Actually, this one didn't get, oh, yeah, here it is. The question is, do you have high blood pressure, or take medicine for high blood pressure. So I'm going to share this screen. And there, everyone. So if you have high hypertension or take medication for high blood pressure, push A. If you don't, push B. So far, 50-50. Great. Wonderful. So this is, hypertension is one of the most common cardiovascular disease risk factors. And I am going to share my other screen. Okay, can everybody see the slide now? Okay. So this is the dirty truth. And if you can handle the truth, we know that heart disease is the #1 cause of death in the US. And again, I don't say this to scare people, just to inform you. And if you could pick one thing to eliminate to help save lives in this country, hypertension is that thing. Over the past 10 years, the risk of having an event due to hypertension has gone up from 11% to 38%. So we're not doing very good. More and more people have hypertension. And in fact, now over 103 million US adults have been diagnosed with hypertension. So how did this happen? This happened because in 2017, we changed the guidelines of what it means to have hypertension from a blood pressure of 140/90 to a blood pressure of 130/80. So that 10 millimeter of mercury difference resulted in over 31 million more Americans being diagnosed with blood pressure. But the interesting component to this is most of these people who now all of a sudden overnight, because of the guideline change, now had hypertension, only about 4.2 million of those Americans actually needed additional medical therapy. Most people could rely on the cornerstone of preventative cardiology, which is lifestyle interventions. So what is blood pressure? Blood pressure is what we measure when fluid or blood is pressed into a blood vessel. And we're actually measuring the force against the artery wall during the heart cycle or the cardiac cycle. So high blood pressure can actually be normal because blood pressure is supposed to go up and down depending on what we're doing. And when arteries stretch, when blood circulates, that actually helps blood circulate through the body and get to all of our vital organs. So more blood pressure often means more stretch. Hypertension, on the other hand, is when we lose regulatory control of our blood pressure. In other words, it's a time when it should be low, but it's high. And that increases the resistance in arteries and leads to poor outcomes. So you can imagine if you're being chased by a bear while you're on fire, you better believe your blood pressure is going to be through the roof. And that could be totally normal because that's your body wanting to get blood to all of your muscles and your brain as you get away from that bear or stop, drop, and roll to put out that fire. So that's a totally normal response. So again, to reiterate, blood pressure normally goes up and down. When we're sleeping or resting, it should be low. But when we have high blood pressure, when it's not supposed to be high, like when we're sleeping or resting, that's what we define as hypertension. And tons of people have this. So 45% of US adults have a diagnosis of hypertension. And that's probably an underestimate because there's a lot of people out there who just don't know, because hypertension, like a lot of cardiovascular risk factors, isn't something that you can feel. So if you're not looking for it, you're not going to know you have it. Again, I treat a lot of people in the VA, and over a third of veterans have hypertension. And once you get to age 60 or above, the likelihood that you have hypertension is over 65%. So again, tons of people, but also tons of opportunity to decrease cardiovascular risk if you do have high blood pressure. We talked about the differences between men and women. It doesn't matter. Men and women are nearly equally affected by hypertension as we age. And again, it's one of the biggest risk factors. So I wrote this little poem, which is my provider forgot to mention you can die from hypertension. It's so interesting to me because a lot of providers will come into the room, they'll look at your blood pressure and say something like, oh, 142/91, not too bad, Mr. Jones, and really continue with the rest of the visit. But that high blood pressure or hypertension, if it truly is that, can really cause serious consequences and needs to be taken seriously. So what do the numbers mean? Well, that top number is the systolic blood pressure, and that's the pressure that your arteries feel when the heart contracts. So heart contracts, blood pumps into your main blood vessels, the aorta, and diffuses to different blood vessels throughout your body. That's the systolic blood pressure. When the heart relaxes, that's what we call the diastolic pressure, and that's the bottom number. And that's when the blood pressure that your arteries are feeling when the heart is filling with blood. And we know that over time, we've had a lot more information about what constitute too high. So you might have been wondering, yeah, why did those blood pressure guidelines change in 2017? Well, the answer is because of data. And we have some really great studies that have specifically looked at older individuals and the risk of having problems with high blood pressure. So these are 3 studies that we'll touch on, and you can see over time, the blood pressure goal first went down, and then it went back up, and then there was a new trial that showed significant benefit from having lower blood pressure, and you can see that it went down again. And this is the AHCC AHA, so the American Heart Association went down here. But at the same time, the American Academy of Family Practice used the same data to come up with a completely different blood pressure guideline for older individuals. And this is what we call guideline discourse. So these are 5 different, very reputable, well-established organizations, including the American Heart Association, the American College of Physicians, the European Society of Cardiology, Hypertension Canada, and the American Diabetic Association. And you can see, depending on your risk factors and your age, these guidelines are not totally consistent. There's discrepancies and differences. And that is something that makes treating blood pressure for providers very confusing, but is also why I love doing the work that I'm doing and why it's so helpful to people as we get older. So I'm going to talk most about the hypertension guidelines from the American Heart Association because that's our accredited body. And I think having an aggressive blood pressure goal is important and makes sense. And I hope to help you understand why I feel that way. But first, just think about classifications. So if you do not take medicine for high blood pressure and your blood pressure on average is less than or equal to 120/80, you do not have hypertension. That's a normal blood pressure. However, if your blood pressure is 120 above 120, you do likely have high blood pressure if you're averaging that on at least 2 visits or checking your blood pressure at home. And as your blood pressure goes up, you can, this is more technical terms, but those are different stages of hypertension and should be treated differently. And so what's the rationale? The rationale is really preventing heart attacks, strokes, and death. So each of these lines represents a different age group. And you can see that regardless of how old you are, for systolic and diastolic blood pressure, there's an increase in mortality as your blood pressure goes up. And this study was a large study that using the data from the Framingham Heart Study, which showed that there's a threshold effect of around 115/75 in all age categories. So once you're above 115/75, you start having increased risks of problems. And again, this is true for women who have high blood pressure. This is true for men who have high blood pressure. So again, here's high blood pressure in men compared to the optimal group. And it doesn't matter constitutes increased risk. So
Adam, excuse
Yes.
me, will you repeat that? At least for my, from here, I lost your entire comment on that last slide.
Oh, this one?
Yes.
Okay, so this is just showing the breakdown of hypertension prevalence by sex and race and ethnicity. And so here you can see the total participants, men and women, and you can see that regardless of race and ethnicity, everyone's at risk, but certain ethnicities have higher prevalence of hypertension, particularly non-Hispanic Black Americans, and that translates into increased mortality. So again, it doesn't matter what race you are, you will have increased risk if you are if you have hypertension, but the highest risks are in non-Hispanic Blacks. But men, women, and all racial and ethnic groups are similarly affected. A lot of this has to do with socioeconomic background, availability of healthcare, healthy foods, and exercise and treatment, but also there's a strong genetic component that goes with it as well. So let's talk about a case. So this is a patient who I saw in clinic. He was a 66-year-old man. He had no past medical history, but when he came into clinic, his blood pressure was 154/92. He weighed 237 pounds and his BMI was elevated at 37. He loves cleaning, French fries, and of course, brandy old fashions because he's from Wisconsin, and he hates dirt and he hates taking pills. And we had a long discussion about whether he had high blood pressure. And this is a really interesting slide that I want to make sure you are aware of. This is directly out of the guideline statement for how to take an accurate upper arm resting blood pressure in the clinic. So you're supposed to have patients sit in a chair with their feet on the floor with their legs uncrossed for 5 minutes, avoiding caffeine and exercise at least 30 minutes before the measurement, ensure that the patient has emptied their bladder or gone to the bathroom, and not talking and not having clothing where the cuff is. So if it's an upper arm, oftentimes that means taking off your shirt or removing the sleeve. And I always laugh at this because I think about my own clinic, which is a cardiovascular clinic and a prevention clinic, and I think about how many times that we're not doing these things. And sure enough, that was the case with Mr. C. So he had just had a large coffee and he had to pee really bad. and he's yakking away while we're taking his blood pressure. And so that's why it's really important to do all of these things and to get an average of at least 2 readings on 2 occasions. So they can't even be the same day before we can diagnose somebody with hypertension. So we rechecked his blood pressure. We ensured that we were getting accurate readings, and it turned out his blood pressure was actually 135/86, which still generated a discussion. And we counseled him on why it's important to think about and treat high blood pressure. And we talked about his risks and medications. And then we thought about when to follow up and reassess. And so with Mr. C, we use this algorithm, which again is directly out of the 2017 hypertension guidelines. He falls into this stage 1 hypertension because of his blood pressure. And it turns out that he's doing a pretty good job with his clinical risk because he doesn't have a lot of other medical problems, and because he's on the younger side. And remember, like we talked about, younger or age is one of the biggest non-modifiable risk factors. So we were able to just focus on non-pharmacologic treatment. So no medications were needed, which he was really happy about. And that really gets into the cornerstone of how to help people with high blood pressure. So I like to talk to my patients, and I'd like to talk to you about the big 4 and how they can impact your blood pressure. Number 1 is obesity. Number 2 is diet. Number 3 is substance use, and we are specifically talking about alcohol use. And number 4 is exercise. So if you are able to get active and change your diet and lose 1 kilogram, so that's 2.2 pounds, you can drop your systolic blood pressure on average by 1 millimeter of mercury per kilogram. So if you're able to lose 5 pounds of weight, you could drop that top number 2 millimeters of mercury. But there's more. If you follow a healthy DASH diet, which we'll talk a little bit more about, and decrease your sodium and increase your potassium intake. So sodium is salt and potassium is found in a lot of fresh fruits and vegetables. You can decrease your systolic blood pressure by even more. So up to 11 millimeters of mercury, depending on which of these you're using. If you decrease your alcohol intake, and that means less than 2 drinks per day for men and less than 1 drink a day for women, you can decrease your blood pressure by another 4 millimeters of mercury systolic. And then if you add exercise on top of that, which also will help you lose weight, you'll see another drop in systolic blood pressure. And the key here is that it doesn't matter what type of exercise you're doing, as long as you're doing it consistently for at least 90 to 150 minutes per week. And that's why we use that 150 minute per week minimum for the AHA recommendations. So if you combine all of these, you can see that with a really good diet, improving exercise, and working on healthy weight loss and cutting down on alcohol, you could avoid having to use medications. So the DASH diet, if you look it up, is the dietary approaches to stop hypertension. And this is a well-studied dietary approach to reduce your blood pressure. And it really focuses on eating foods that are low in saturated fat and cholesterol, eating plenty of fresh fruits and vegetables and low-fat dairy products, and cutting out red meat, sweets, and sugar-containing beverages. And the studies have shown that you can really have that significant effect in less than 2 weeks or less. So Mr. C came back to clinic and he'd cut down on his brandy old fashions. He's following the DASH diet and really cut down on sodium. He's been more active by cleaning more aggressively, and his home blood pressures have been in the 120 to 125 range over 80 to 85. So he was able to avoid pills by making some lifestyle changes. But a lot of us do end up needing medication to treat hypertension. And that's okay. On average, an adult who's diagnosed with hypertension needs about 2.5 medications to control their blood pressure. And I hope to show you that that not only is that important for some people, but it can actually prevent bad outcomes from happening, like heart attacks, stroke, and death. So this is one of the landmark trials that came out in 2015 that looked at standard blood pressure control versus intensive blood pressure control. And what that means is they took two groups of people and nearly 4,600 or over 4,600 people in each group and randomized half to standard treatment, which was like the 140 millimeters of mercury group, and the other half to intensive treatment, where they tried to get their blood pressure to 120 millimeters of mercury for that top number. And what the investigators found was that those who were on the standard treatment had more risk of cardiovascular disease events and death than the intensive treatment group. And this is the slide that shows death. The previous one was any event. And then they went one step further and broke that down by age. And you can see this is called a forest plot. So this shows one here is kind of a coin flip in terms of risk and how much each thing affects you. And breaking it down, if you were over 75, you actually had the most benefit from intensive treatment compared to standard treatment. So older individuals benefited even more. So lower blood pressure meant fewer deaths, and this was seen most prominently in the oldest age group. And again, there was this graded improvement in terms of improving blood pressure depending on how low you were able to get your blood pressure. Again, which is why the guidelines really focus on decreasing blood pressure to as close to 120 as possible. So again, in adults 75 years and older, treating to a systolic blood pressure of less than 120 versus 140 had a significant benefit and had no effect on gait speed or changes in mobility. Another study that came out in 2008 looked at the oldest old, and this was looking at treating people who are over 80 years old with a blood pressure of 160 to a systolic blood pressure goal of 150 or not. And you can see in the intensive treatment group, they did lower blood pressure. And after 4 years of follow-up, the group who was in the intensive blood pressure control group had fewer strokes, less heart failure, and most importantly, fewer deaths. The SHEP, which is the systolic hypertension in the elderly program, came out even earlier than that. This was a study that was done in the 90s, and they were looking at systolic blood pressure over 160 in people who were 60 years old. And same thing, when we looked at blood pressure in the intensive treatment group, those who had more intensive blood pressure control in this study, the outcome was strokes. And you can see this black line is the intensive treatment group had fewer strokes than the normally treated group. So in summary, one size for blood pressure control really fits none, because hypertension, we know, is a major cardiovascular disease risk factor that can over time cause death, heart attacks, and strokes. But we have to get good information. So when you're having your blood pressure taken in the clinic, make sure you're doing all of those things right and checking with your provider. So make sure you go to the bathroom. Make sure you're not smoking or exercising or having caffeine before you get your blood pressure checked. Make sure you're sitting for 5 minutes before they check your blood pressure. And then, even more importantly, we now have very accurate upper arm home blood pressure monitors that you can go out and buy at any Walgreens or on Amazon for between $25 and $35. As long as they are upper arm blood pressure cuffs, the majority that we've tested in our clinic are incredibly accurate. If you're a veteran, we will provide you a blood pressure cuff from the VA for free. So it's important to check your blood pressure at home because lots of people might have high blood pressure in the office or clinic, but at home it's completely normal. Diet and lifestyle are important for everyone, regardless of your race or ethnicity or your gender. But it's important to talk to your provider about hypertension and high blood pressure and about your specific goals. Okay, we'll pause. Any questions? I see some questions popping up in the chat, which is great.
Yes, we do have some questions. I think you've answered one of these. The question was about the white coat syndrome and what do you think about that? You mentioned the importance of how the blood pressure is measured, but
yeah, I can touch on that a little bit. So white coat hypertension is just kind of what I was referring to before, which is where you go into the office or clinic and your blood pressure is elevated, but when you check it at home, it's completely normal. And there's different studies have shown different percentages of people in terms of prevalence of white coat hypertension, but it can be as high as 10 to 15% of individuals. And generally, if you have high blood pressure just when you're in clinic, but not at home, if you truly have white coat hypertension, that does not mean that your risk of a heart attack, stroke, or death is higher. You're actually the same as someone who doesn't have high blood pressure. And that's because you're not at clinic or in the hospital most of the time. And so remember, the damage that's caused by hypertension over time is cumulative. So if your blood pressure is higher longer, you're going to be worse off. If you're just, if your blood pressure bumps up while you're in clinic, then you might but goes back to normal when you're at home, then you're not going to have a higher risk. There is a condition that's the opposite of white coat hypertension, which is dangerous, and that's called mast hypertension. And it's exactly the opposite of white coat hypertension. It's when you go into the clinic and your blood pressure is normal, but at home, when you check it, it's high. And that, as you can imagine, does confer an increased risk of cardiovascular disease. Luckily, the prevalence of mast hypertension is far lower, on the order of 1 to 2% of individuals, but it's still a plug and to make sure that you do check your blood pressure at home with an upper arm blood pressure cuff. As we get older, they sell cuffs that go on the wrist or the finger. Those cuffs are just less accurate, particularly for older individuals. And they can falsely elevate or lower your blood pressure depending on how they're used or which device you're using. Great question.
Okay, a couple of other ones. What are the dangers of having low blood pressure?
Great question. So we've talked a lot about how lowering your blood pressure as low as you possibly can is helpful. We do see some people whose blood pressure's in the 80s or 90s who have no symptoms, and that is actually just fine. So remember, blood pressure is just a number, and we as providers get kind of, we get we like data. And so sometimes we'll see these numbers and want to treat them, but it's really important, again, to take that into consideration with the whole patient. Because if you have a blood pressure that's in the 80s or 90s, but you feel fine and you're able to do all the things that you want to do, and you're not getting dizzy or lightheaded or passing out, you are actually at the lowest risk. And this comes from stroke data, where we've shown that regardless of how low the blood pressure is, lower equals less risk. But as we talked about, if you are having side effects from your medication and you're having low blood pressure that goes along with dizziness, lightheadedness, or passing out, that's a sign that you're probably taking too much medicine and your doctor should consider backing off. But that's a discussion that you need to, and a decision that should be made with your provider, because different medications can impact you differently and have more effect, particularly if you have multiple medical problems, because some blood pressure medicines actually treat multiple conditions.
Okay, another question is, can a slower pulse contribute to hypertension, increase pulse volume?
Great question. A slower pulse can contribute to higher blood pressure. And the reason is very physiologic. So your body needs blood, and the physiology of your body is primarily going to help make sure that blood flow is preserved to our favorite organ, the brain. Because if your brain's not getting blood flow, then you're going to pass out, and that's not good. So when your pulse is low, remember there's two ways that you can increase blood flow to your organs. One, you can increase your heart rate, or two, you can increase the cardiac output by constricting or dilating blood vessels. So what we see a lot of times in people who have too slow of a heart rate, who don't have a normal response, meaning that if your blood pressure drops, the heart rate should compensate by squeezing faster. Some of those individuals will see a paradoxical increase in blood pressure because your blood vessels are tightening up, trying to preserve blood flow to the brain. So that's an instance where sometimes the physiology definitely can be impacted by a slow heart rate. And that's the kind of the big term, or the medical jargony term that we use, is called autonomic dysfunction. And the autonomic nervous system is what's responsible for making sure that all of your organs get blood flow without us thinking about it. But yes, that can definitely happen.
Another one, if you take medication and your blood pressure does go down, is that the same as if you have low blood pressure without meds? Is that the benefit?
So if you have high blood pressure and you're taking medicines to lower your blood pressure, and your blood pressure is now in that normal range, that is ideal. And hopefully, with the combinations of medicines and a healthy, active lifestyle, sometimes what will happen is people make very significant lifestyle changes and their blood pressure goes down to a level that they start having symptoms like lightheadedness or dizziness. And then we can start peeling back some of those medications so you don't have to take as many pills. And that's really the ultimate goal. But like I said, most people, even if they're doing everything right, end up needing on average 2.5 medications to control their blood pressure. Great question.
We have a couple more. Can you say more about the BMI index, or talk a little about the BMI index and whether it's important? This person says that they're 5'10", have never weighed over 175. They're physically fit, but the last BMI was just 1 point below being labeled obese.
Yeah, that's a great question. So the body mass index takes into account your height and your weight. So it's one of the markers that we use for obesity because of making sure that we're accounting for how tall people are. What it does not account for is your waist circumference. And that's another marker of what we term metabolic syndrome. In other words, depending on how your weight is distributed, can definitely impact your cardiovascular risk. So even if your BMI is a little bit high, again, muscle tends to weigh more than fat. And so depending on your frame and your build, BMI might not be, the perfect measurement, but it's very good. And most of us, if your BMI is over 30, probably do have some extra weight to lose. Even if you feel like you're robust. So again, that's a very individualized question that would be important to talk to your doctor about. But we do know that obesity is, particularly central obesity, where you're carrying your weight in the middle, is a significant risk factor for high cholesterol, high blood pressure, and developing diabetes.
Okay, and one more before I think we're ready to move on, and that's, can you recommend a home blood pressure monitoring device, and how do you keep it calibrated?
Yeah, great question. So like I said, really, if you go into any pharmacy, the brands that we've tested in our clinic, in addition to the ones that you can get for free for veterans from the VA, are called Omron, OMRON. That's the brand name. But we've tested lots of them, and they're all very, very similar. So the keys are: make sure it's upper arm, so it goes on your upper arm, not on your wrist or your finger. Make sure that the cuff fits. So each cuff will have, in centimeters, the dimension of the cuff for your arm, and make sure your arm is within that dimension. If it's not, it's going to give you a falsely low or high reading. And also it should be automated. So it should just be a push button. It blows up automatically and gives you a digital readout. If you have those components, the vast majority of these are very effective. And the ones that cost, $35 or even $30 are no better or worse than the ones that cost $100. And a lot of insurance plans will help cover those as well. So that's something to talk to your doctor about as well, if you have concerns, or particularly if you have trouble affording that.
Okay,
Great
great.
question.
I think that's all the questions we have for right now.
Excellent. Oh, I love it. I love how engaged you all are. So we are going to shift gears, and we're going to talk about another very prevalent problem that's a cardiovascular disease risk factor, and that's dyslipidemia, or high cholesterol. So again, I think in the interest of time, just because we've had so many questions, we'll skip this one because I already know the answer, which is lots of people have high cholesterol and take medicines for high cholesterol. So here's the things to remember. So cholesterol 101. Cholesterol is a necessary building block for cells, particularly cell walls, and is used in the production of hormones. And it comes from two sources primarily: the liver, where we make cholesterol from other different types of things, and from diet, where we eat it. And it comes in different flavors that you've probably heard about. And that includes total cholesterol, which is the good plus the bad cholesterol, good cholesterol, or high density lipoprotein cholesterol, or HDL, and bad cholesterol, which is the low density lipoprotein cholesterol. And then there's triglycerides, which are the fats that circulate in your bloods and get turned into these other different types of cholesterol. And cholesterol is important because think of them as these little tiny balls that are in your artery. And you can imagine that those little balls are bumping into the wall of the artery, causing damage and inflammation. So if you have very high cholesterol, you're going to have more of these little balls that are bumping into the artery, particularly the low density LDL, bad cholesterol, which are small and dense, bump into the walls and even infiltrate into the artery walls and cause plaque. And plaque is essentially your body's response to that injury, and your body trying to eat up those cholesterol particles and then heal the damage where that artery was affected by cholesterol. And so you can imagine that plaque can happen in any artery, but the ones that we worry about most are when you have a plaque or blockage in your heart arteries, which can lead to a heart attack, in your brain, which can lead to a stroke. But really any artery can be affected. Your lower extremity arteries, which can cause low blood flow to your legs and muscles, making activity difficult. Plaques in the kidney arteries can cause kidneys dysfunction. So really no artery is safe, and all of these arteries are going to be affected by your cholesterol. And what a lot of people don't know is that cholesterol changes depending on how old you are. And this is for both men and women. So here on the right, we have the mean total cholesterol with age. And you can see for men in green, it goes up and it peaks around, the 50 and then actually starts going down. In women, cholesterol is lower, and then around 50, it actually crosses and is higher than men's cholesterol. And this is where that protective effect of all the hormones that women have as part of childbirth and reproduction are coming into play, protecting. And then women go through menopause, and all of a sudden your risk is in terms of total cholesterol is higher than men's. And this is why we start seeing an equalization of cardiovascular disease events in men and women as people get older. So again, this patient is a 65-year-old farmer. He had hypertension actually, this was the woman. A woman. She was a farmer, but they came in together, and she started asking me about her cholesterol, and she really didn't want to take medications. But I think the things that we have to remember is that, again, cardiovascular disease is the #1 cause of death in older adults, and 60% of people over age 85 are responsible for those events. Statins again are the main cholesterol medication that have been used. They have been around since the 1990s and have 28 large randomized controlled trials that have looked at their effectiveness, and they have been studied in nearly 200,000 individuals. But the problem is a lot of these patients were younger. So less than 8% were over 75. But this is a huge, huge industry because statin treatment alone by 2030 is expected to be more than $70 billion. So a huge industry. And why do we care? So we care because cardiovascular disease risk increases as LDL increases. So just like with hypertension, as your blood pressure goes up, your risk goes up. Same exact thing with the bad cholesterol, the LDL. As the LDL rises, risk of stroke, coronary artery disease, and death increases. And again, lifestyle is the key strategy for improving outcomes. So if we think about diet and LDL bad cholesterol, you can see here, this was a study that was done in 2007, where about 372 individuals were randomized to either the Mediterranean diet plus virgin olive oil, Mediterranean diet plus nuts, or a low-fat diet. And you can see that those people who were on the Mediterranean diet had the lowest or the most reduction in LDL cholesterol. And this translates into less events. So here's the control diet, here's the Mediterranean diet and the Mediterranean diet with nuts. And you can see that both of those groups had significantly lower cardiovascular disease events over 5 years. So definitely diet is a big component. But what about statins? And again, we're going to focus on statins because that is one of the most commonly prescribed medications. And I have a feeling that a fair number of you in the audience are taking statins, have taken a statin, or are thinking about taking a statin. So here's the first challenge that I have as a cardiologist, is that we tend to prescribe statins for people who don't have known heart disease based on risk. The problem with our risk calculators is that the guidelines suggest that we should treat or start statins if you have a 10-year risk of having a ASCVD, or atherosclerotic cardiovascular disease, over the next 10 years of greater than 7.5%. The problem is that all men over 65 and all women over 71 meet that criteria regardless of anything else. So age alone already puts you over the threshold once you get older. And this does not mean that we should be starting everyone on a statin. It means that we have to have a discussion. And just like with the hypertension guidelines, there's significant discord in different guideline bodies about at what age we should be prescribing statin therapy. And you can see there's weaker evidence as people get over 75 and 80 because there's less data. Remember, we only had 8% of those people in the trials. So here's our patient again, and I just want to kind of give you two different scenarios because, again, we have to talk about risk. So if you start one patient on statin therapy, the same patient doesn't get statin therapy, all of a sudden, this patient who wasn't on statin therapy has a heart attack. So they had a cardiac event at age 68. Well, now, because of that event, it's highly recommended that that person start on statin therapy to prevent future cardiovascular disease events and should be continued on that statin likely lifelong, or until they're no long until their life expectancy is less than 2 or 3 years. Versus patient B, if you start that person on a statin at 65 and all of a sudden they have no events and they get to 75, then they're still in this group that hasn't had an event, and there's data to suggest that maybe we should stop their statin once they get to that age threshold. But we'll talk more about that. What do all the guidelines agree on? Again, and I'm going to keep coming back to this, healthy, active lifestyle is key. So fast forward 10 years, they've both now been on statins. They're doing much better. Their cholesterol's improved. And, but still, now we're in this weird conundrum of what do we do for an adult who's over 75? Should we continue their statin? Should we change the dose? And there's really no randomized controlled trials looking at different statin doses, or high intensity, moderate intensity, or low intensity statins in this older high risk adult group. It also doesn't apply, and we haven't studied well-studied people with diabetes or who have a very high risk of an event greater than 20%, or severe high cholesterol with LDLs over 190. Most people would agree that this group will benefit from high intensity statins and should be treated. So when we think about primary prevention, so again, this is people who haven't had a heart attack or stroke, there's good data to suggest that people less than 70 should probably be on statin therapy if their risk is greater than 7.5. If you're over 75, then we really have to have that risk benefit discussion that we talked about at the beginning and talk about the benefits and harms of statin therapy, really thinking about your comorbidities, meaning other medical problems that are going to impact your health and your overall prognosis and quality of life. This is another important aspect when frailty comes into the equation, because people who are more frail, we know are more likely to have events and might not have as much benefit from statins, and whether or not people have cognitive impairment. And this goes back to the fact that, if you're not living your fullest life because you have dementia, again, there's a risk and benefit conversation that needs to happen depending on that. And sometimes my patients are so cognitively impaired that I can't even have that conversation with them. I have to have that with a family member or their healthcare power of attorney. And that becomes even more complicated and difficult because, one, maybe they hadn't had those goals of care conversations before, and two, now somebody else is trying to put themselves in the shoes of the patient and help make decisions. But regardless, I do want to show there is good data for people who are greater than or less than 60, 70, 60 and 70 years old, based on these large randomized clinical trials showing that treating, this is the number needed to treat. So each person treated in these studies cumulatively would protect from one cardiovascular event. And so in people less than 60s in ASCOT, we had to treat 128 patients to prevent one event, but in older individuals, we only had to treat 82. Same with Jupiter and Hope. Younger people, we had to treat more people before we saw an improvement in preventing one event. So for people over 70 in Jupiter, we only had to treat 62 individuals with statins. And that may seem like a lot, but I can tell you some randomized clinical trials that actually get into guidelines might show a number needed to treat of, over several hundred. And so this is actually pretty good in terms of how many people we need to treat to prevent one event when you consider how many people have high cholesterol. So again, statins benefit by trial for older individuals. So different trials showed slightly different benefits. The 2018 guidelines for cholesterol reduction gave statin therapy in adults greater than 75 a class 2 recommendation. So class 1 is when, the strongest recommendation, and class 2 is kind of intermediate or weaker recommendation. But in our friends across the pond actually do have a strong recommendation for moderate intensity statin up to in people up to 85 years of age. But again, this isn't based on randomized controlled trial data. This is more on expert opinion. What do I think? I think that if you are a robust older adult and you're on a statin and you're tolerating it without problems, you should definitely continue on that statin. And this is data that's from an observational trial. So it's not a randomized controlled trial, but here's all people over 75 who continued their statin and those who discontinued their statin. And you can see over the 3-year follow-up, the people who discontinued their statin had more events than the people who continued on it. In terms of safety and tolerance, that's also another big question that we get in clinic is, I'm worried about, statins causing muscle aches or problems. And there's been a lot of data, over 11 randomized controlled trials looking at over 18,000 patients who are older, so a mean age of 73 years old, with 43% women. And really, there was no difference in increased adverse events and no increased muscle-related symptoms. That doesn't mean they don't happen. So you might be someone who has muscle-related symptoms and can't tolerate a statin. That's okay. You need to talk to your provider. We've got other options if you need to be on a cholesterol-lowering medication. And this, again, is just one of those forest plots that shows all of these different trials had no difference in terms of muscle outcomes. So in summary, cholesterol levels do change over time. Lifestyle is key. Statins work, but not necessarily right away. Remember, the benefit for statins is likely going to be most impactful over 5 to 10 years. So time matters. They're safe and effective, but there's definitely less data with older adults. So the last part of the talk is really considering discontinuing therapy. And this is something that can really be insightful to people when I talk about, because most of the time you go to your provider and they're probably trying to encourage you to add a medication and less likely to take medications away. And I always make it a case, especially in my older patients, to go through all the cardiovascular medicines and talk to my patients about why they should take it or shouldn't take it, and if they're having any problems or issues with each medications. And I really try and put it in the framework of the 5 M's. And this was presented by a group out of McGill University a few years ago. And the 5 M's are mind, mobility, medications, or using polypharmacy, so multiple different pills, multi-complexity, meaning multiple different medical comorbidities, and matters most. In other words, what matters most to the patients. And we also have to think about this in terms of risk, because there's a short-term risk versus benefit for some medications and a long-term risk versus benefit for other medications. And a lot of times, because age is such a strong risk factor, we see that there are a certain population of robust older individuals we need to de-risk, and other younger individuals who actually should be treated at higher risk, depending on their other risk factors. So our traditional models that incorporate age might not be as accurate as we once thought. And so we really, again, need to think about age not so much as a number, but really put that into the context of the individual. And I'm going to skip this slide just in terms of time, but basically this is a potential algorithm that you could go through with your provider to see if you should stay, on a statin therapy. But that really, is dependent on all of these factors, which is having an honest discussion about risks and benefits of medications. For cardiovascular disease, really reinforcing lifestyle and treating people who will benefit most. If people have significant comorbidities like kidney failure or heart failure, then those people typically don't benefit as much because their survival likelihood is much lower. And put that into context of the 5 M's. And I always make sure to listen to my patients, because I always tell people, I know medicine, but you know you better than anyone. So I need to put whatever we're going to do in context with what works in your life to have the best outcomes. And so this is your job, which is initiating some of these more difficult discussions and really deciding about talking to your provider about what matters most to you. And so if you are thinking about whether or not you should be on a medication. So again, this study was looking specifically at statin therapy, but this could really apply to any medication. What is the evidence? What is my life expectancy? What is the benefit, and what are my values, and what are the risks of the medications? And based on that in-depth discussion, my hope is that you and your provider can make a good informed decision about whether to start, stop, or continue a medication. But that's a lot of times easier said than done. So a few tips about how to talk to your provider about prescribing. First, ask. If you ask your provider, what's this medicine for? What is it helping me with? And go through each one on your medication list. That can be really helpful. It doesn't need to be done all at one visit. This is something that can be broken up over different visits, but knowing why you're taking medications is incredibly important. So find out from your provider, what does each medication do? What is the evidence that it will help? a lot of medications in the field of medicine really don't have that much evidence. It's more anecdotal. And so understanding that can really help you decide if it's a medicine that's worth taking, particularly if it's causing side effects. Could it cause harm? Is there a downside to taking it? And is there evidence for me? That means you are an older individual. And like I talked about, these things are not unique to cardiovascular disease studies. Most trials really are enrolling fewer people in the older demographics historically. That's changing though. So there's been a big push through the National Institutes of Health to make sure that not only are we enrolling people from all races, ethnicities, and gender, but also from all ages. So my last words, you matter, your health matters, stay active. Lifestyle changes do work for cholesterol, hypertension, and lowering cardiovascular risk. Medications, when needed, can be safe and effective, but talk to your provider because you shouldn't take medications you don't need. And make sure you have that goals of care discussion with your provider. And I think we just got into the top of the hour, so I understand if people have to go, but I am happy to stick around and ask questions if people have them.
I think we are just about out of time, but there is one other question that had come up, and that is, we've all been thinking a lot about the COVID-19 recently. Does contracting COVID-19 increase the risk of heart problems?
Great question. The short answer is we don't know because we don't have enough long-term data, but there is data to suggest that especially serious cases of COVID where you're hospitalized or have to be on a ventilator do have increased risks of cardiovascular complications. But there's still a lot more that we need to learn. And a lot of it has to do with how the coronavirus impacts our blood clotting cascade, particularly in serious illness.
Okay.
Good question.
And if you can stem one more, what is the role of stress? What role does stress play in cardiovascular health, and what might be the best strategies for reducing that? And for example, is mindfulness training, is that better than exercise, or one or the other, or some combination?
Great question. Yeah, we know that stress can definitely impact cardiovascular disease outcomes, particularly in people who have, ongoing chronic stress. So that doesn't mean, you're worried about something, for a couple weeks and then, that stress goes away. But people who are under chronic stress definitely have increased chronic inflammatory markers, and those inflammatory markers, just like cholesterol, are circulating in the bloodstream and causing inflammation to arteries, which then can cause increased risk of heart attacks, strokes, and death. A lot of things have been studied in terms of mindfulness-based stress reduction, and there have been some modest improvements in cardiovascular disease outcomes. So my thought process is the risk of doing mindfulness-based stress reduction is probably pretty low, right? It's probably just the time it takes you to learn the techniques and to actually do them. Whereas if the benefit is, could be significant and you're already doing all of the other things that you should be doing, I don't think I think that's a reasonable approach. But the data is nowhere near as strong as things like, hypertension and controlling your cholesterol. So if you were going to pick one or the other, I would definitely say there's better evidence to really try and reduce your cholesterol. But we're, again, got to treat your whole body. And if you are having increased stress, that impacts you every day. And so definitely being proactive and trying to help with that is going to likely help with more than just your cardiovascular health.
Okay, and we have one, I think one last one, and I'm not sure I understand all of the acronyms, but the question is it safe to take HCTZ with a sulfa allergy?
Yeah, so HCTZ is a blood pressure medicine that's commonly known as hydrochlorothiazide. Hydrochlorothiazide is a thiazide type diuretic medication that works in the kidneys to help you pee out more salt. So it's like a gentle diuretic. And there is some overlap with people who have sulfa allergies and thiazide diuretics, but I'm pretty sure it's only about like 10% overlap. But I don't know the exact numbers off the top of my head. So I think that that's something definitely to talk to your doctor about. But the other important thing to remember about thiazide diuretics is if you look at the randomized controlled trials, they actually didn't use hydrochlorothiazide. They used a different medication called chlorthalidone, which is a cousin of hydrochlorothiazide. So I always tell my patients who are taking hydrochlorothiazide, they should probably be on a different medicine of a similar class because those are the ones that have been actually studied. So that's another thing you might want to talk to your doctor about and why it's important to make sure your doctors know the evidence behind what they're prescribing or continuing to prescribe. Great question.
Thank you so much for all of this great information, Dr. Gepner. You've given us so much to think about and some really great strategies for caring for our hearts, for really loving our hearts today, not just on Valentine's Day, but the days and weeks and years ahead. So thank you so much.